So there are quite a number of talks, both at ASCO this year and following up here in ESMO, just about the general utility of circulating tumor DNA assays, or what we call liquid biopsies. So I think there's two things really. What is the best assay? Do you need an assay that just looks at 50 genes, or should you go out wide to 300 or even now 500 genes? If you're going to do that, in what context and why are you doing so many genes? There's a lot of noise that you'll pick up. Are you looking at tumor mutation surrogate markers or tumor mutation burden surrogate markers, or are you actually screening for a very rare NTRK fusion, for example, or ALK fused bowel cancer? And I think there was some very nice data around whether we could use it to really change management even in the curative setting, with trying to determine whether you had any residual disease at all, maybe after bowel surgery, and if you didn't, whether it would change your management of how much adjuvant standard of care chemotherapy you did in bowel cancer, and if after 1 or 2 months you still had residual disease. Luis Diaz gave a lovely talk about maybe kind of doing some really nice kind of stratified trials of molecular therapy based on those targets. So I think that's almost as exciting as the whole thing about immunotherapy, because this is highly useful for the daily practicing clinician. It's very helpful for our patients to understand the efficacy of some of the treatments. And this doesn't have to be around immunotherapy space. It could be around just standard of care surgery, radiotherapy and chemotherapy and other targeted agents. So I think that going forward it's going to be a really exciting space of how we're going to use and which liquid biopsy tests we should use.